the other drug that exists in this space, of course, as you brought up, is Sacituzumab Govitecan. So the ASCENT-03 data, do you want to take us through that a little bit?
Absolutely, yeah. So Sacituzumab Govitecan, which is another antibody drug conjugate, it is also approved in similar setting. The clinical trial was very similar to, the TROPION. It basically enrolled patients in the first-line setting, metastatic, unresectable. They haven't had any other treatment, and these are patients who are ineligible for immunotherapy. So very similar patient population. You can always tease out some minor differences, but overall we are targeting the same patient population with these two trials. And we definitely this trial study showed significant progression-free survival benefit, and even in a trend towards OS benefit. So it was a positive trial, and the drug is approved, and it's equally good options. There are definitely some minor differences in toxicity, patient population that got enrolled, but overall I consider both drugs to be equally effective.
Yeah, absolutely. I think it's been a trend lately in our trial data that's coming out that we tend to see these waves of information that force us to make these complicated decisions. Right. Again, good thing for patients, sometimes tough thing for us. One of the things that strikes me about ASCENT-03 is the statistical planning. Of course, we talked about the dual primary endpoints, and then also the presence of crossover for patients that are on the control arm of the study, and then we're able to receive SG in later line settings. So Ryan, do you want to talk about a little bit about that whole concept of crossover and what it means in trials and what it does for our endpoints?
Sure. So taking TROPION-Breast02, there was no FDA indication for triple-negative breast cancer and Dato-DXd deruxtecan, so there was not the option in that study to receive Dato-DXd deruxtecan in the second line. There was no approval for it.
Standard of care.
Yeah, absolutely. Whereas with the ASCENT with Sacituzumab Govitecan, those who received cytotoxic chemotherapies were eligible, and that was, in the second line setting per ASCENT, standard of care to receive that. So appropriate to do so, but that can have an impact on overall survival if you're receiving the drug in the second line setting. And I think about 30% of patients in the TROPION-Breast02 received some form of ADC, but it was not Dato-DXd deruxtecan.
Yeah, and I think, as these are all the sort of devil in the details with clinical trial design, right? If you're reading just headlines, it can be challenging to sort out. How do you practically view one drug having a survival benefit and one not? Does that eliminate an option, or tell me how you work through that in your head?
I think the crossover matters deal to. We should not remove. We should not allow crossover. Okay, I think if that's approved, it's there. It should be ethical to do so.
Right.
It is something where we take it with a grain of salt. And we don't just say, oh, one has an overall survival benefit and one doesn't. We have to look at the design. We have to go into the devil in the details to acknowledge that fact. But I think both show the fact that we need ADCs in the first line setting. And both of these were PD-L1 ineligible. Having PD-L1 eligible, so the PD-L1 positive patients, I would certainly consider the combination with Sacituzumab Govitecan plus Pembro. But talking about patients through the quality of life, the side effects, the treatment schema about one being once every 3 weeks or 2 weeks on, 1 week off. These are things that should matter to patients, and they should have a voice in this too.